research at CAM? Well, research into all aspects of substance use disorders is an integral part of our standing mandate from the ministry. From the very beginning, a part of the annual budgetary amount has been ring-fenced to promote research, especially student research. Over the years, the Center for Addiction Medicine has pursued multiple lines of inquiry. 4 overlapping but distinguishable themes have emerged over the years: the study of the epidemiology of substance use disorders in India, exploration of a mechanistic understanding of vulnerability to and the development of addictive disorders, exploring effective treatments, and finally the role of policies and advocacy with special reference to India. A major contribution during the period under review was our collaboration in the conduct of the first National Mental Health Survey of India, 2016, which confirmed our previous findings of the seriously high prevalence of alcohol and tobacco use disorders, as well as the very high treatment gap. There have also been notable collaborations in this period with the World Health Organization and Thai Health in tracking alcohol's harm to other than the drinker, which is a very major thrust area of the World Health Organization. CAM also collaborated in the conduct of the National Survey on Extent and Pattern of Substance Use in India 2019. A major thrust of our research since the last 30 years has been to better understand the mechanism of addiction. We have repeatedly documented that addictive disorders, like most psychiatric disorders, do not start de novo. Long before the first sip or the first puff, children who will go on to develop addiction later in life suffer poorer psychological abilities, which are linked to deviations in their brain development trajectories. In 2016, we were awarded the Newton Bhabha Award, funded by the ICMR and the MRC UK, to set up one of the largest international neurodevelopmental cohorts, the Consortium on Vulnerability to Externalizing Disorders and Addictions. This has set up a database and a biobank of 10,000 children, adolescents, and young adults from 7 sites across India, which is being now utilized to study how inherited genetic programming is continuously modified by exposure to environmental influences throughout the lifespan, be they psychological stressors, nutritional or environmental neurotoxins, and how these interactions ultimately shape brain development towards health or vulnerability to disease. We do anticipate that some of our learning will help develop preemptive and preventive interventions as opposed to the palliative treatments we have today. Some of the early papers utilizing this data include the creation of an Indian brain template and brain atlas, a study of epigenetic influences on early childhood adversity in the future ability to cope with stressful situations, the impact of exposure to neurotoxins like arsenic, PM 2.5 in air, water, and earth on the developing brain and future cognitive abilities. We have similarly been also part of another large cohort of persons with common psychiatric illnesses, the ADBS, which was set up to promote a better understanding of the mechanisms of mental illness. There have been a number of multidisciplinary initiatives on the effectiveness of various treatments for addictions, some listed here. And as far as the role of policies and advocacy go, very recently, the COVID-19 pandemic has been the most important disruption of our times. Naturally, we were keen to understand the effect of these disruptions in terms of supply, availability, and subsequent distress and disease, especially in the light of shaping drug policy and advocacy. Now, excellent research requires excellent teams. We have been fortunate to have had the guidance and companionship of brilliant collaborators, both intramurally, colleagues from other departments at NIMHANS, as well as extramurally, collaborators across the world.
Discussing about how CAM responded to the COVID pandemic and the disruptions that it caused. And also I will discuss a bit about how we are looking at data and how it can help us in making some organizational decisions. So coming to the COVID pandemic, as we all know, the OPDs were closed for some time. There was a lockdown. So most of the departments, clinical departments, saw a decrease in the number of patients that were coming to us. We also had a similar trend. In fact, in perhaps for the first time, there was a sustained decrease in the number of patient contacts in the OPD. But what we also saw, and perhaps a bit unique to Center for Addiction Medicine and our work, was that this was more of a shift because patients decreased in OPD, but the workload in the short stay ward or the emergency room increased quite a bit because during the lockdown, there was a spike in alcohol withdrawal cases and complicated alcohol withdrawal. So how did we cope with this? Well, we tried to ensure the continuity of care by mainly two initiatives, one of which was cloud telephony. So this was a very simple solution. It was just that this kind of system allows a single phone number to keep routing incoming phone calls to various doctors. And it also enables phone number masking. So there's no concerns about privacy. And another initiative was the e-consult initiative, which was a part of virtual knowledge network. So we'll discuss about them a bit in detail. We started placing calls to our patients who were in touch with us in the preceding 2 to 3 months quite early. In fact, we were up and running by about 25th of March. And the last OPD that we had was on 22nd of March. And the reason why we felt kind of propelled to do it was because a lot of our patients, and this is a post-hoc analysis that we have done, a lot of our patients were on medicines, which if they discontinued suddenly, they would have had either a life-threatening withdrawal syndrome or at least a severely discomforting reaction. So overall, the effort was quite successful and we could contact about 2,000 plus patients over the time. We thought that this would be a short period of cloud telephony, but then we realized that even in May, we were not able to resume OPD services with the same vigor as we would want to. So therefore, a second wave of the same intervention was done in May. Another initiative was the e-consult. So e-consult, to put it simply, was a healthcare provider to a healthcare provider consultation. And the whole idea was that because patients cannot come to the specialized centers, they may be going to general practitioners and other healthcare providers near them. And it will be useful to guide them, to guide these practitioners in giving good quality care. And this initiative also was well accepted, and we have published the research on that. We also, so we looked at COVID-19 as kind of the biggest natural experiment that probably in the modern history. Some of the findings that we have got is, of course, an increase in complicated alcohol withdrawal. And this is not a obvious or a trivial finding because this has a number of implications for public health policy. Similarly, we also, so across the world, as we know that the rate of road traffic accidents and head injuries came down, we saw the same in our department when we analyzed data in collaboration with senior faculties from neurosurgery department. But what we did additionally was to see, is it the decrease in mobility? And therefore we used Google community mobility data for this. Or is it the decrease in alcohol sales? And for that, we used the day-to-day total alcohol sales in Karnataka. Which of these two explain the decrease more efficiently or to a more extent? And this is a manuscript which is under review right now. Coming to the second section that I wanted to discuss is data-driven decision-making. So this is just a process of making some organizational decisions based on actual data rather than on some preconceived notion or what one feels or one's intuition while working. So as you know that Center for Addiction Medicine was perhaps one of the early starters of trying to digitize all the patient contact and electronic health records. We are now coming up with kind of a dashboard which is a standard in such systems. but is new for our system, where we could track how the pattern of patient presentation is changing. To just give you two quite instructive examples, if you look at the graphs here, what you'll see is that in 2020, we felt that the proportion of new cases with alcohol use disorder has come down. So that's one question to answer. How did that happen? Because the majority of our clientele has always been alcohol use disorder. What we see is that this might be because the proportion of cases with opioid use disorder really went up in 2020. So this made us look back at what is happening and what might explain it. And there's a manuscript on the same thing. There seems to be a new chemical on the block, which is being abused quite frequently. Another example is, as you know, and has been discussed in this presentation, we have a robust follow-up counselor system who call patients to ensure that they do come for follow-ups, because follow-up is a very essential part and predictor of treatment success. So what we are looking at now is a pattern analysis of our success and failure. So as you can see at the bottommost graph, for some reason, these patients got very less number of phone calls from us, and they also did not come by their own self. So the next question is to look at what is the profile of these patients. Why did we end up missing them? So these are some of the examples of how we intend to use data collected rather passively to make decisions and changes in the organization.
Toxicology laboratory was established in 2008 with minimum infrastructure. Further expansion happened in 2014 by Union Health Minister. NIMHANS Toxicology Laboratory now is recognized by World Health Organization as a tobacco testing laboratory. This laboratory is part of the global tobacco testing network, which includes almost 90 countries. From Southeast Asian region, we are the representative. India is the only representative. And from India, NIMHANS and Director General of Health Services are the member of this network. Ongoing projects include testing of smoked and smokeless tobacco products in Southeast Asian region for nicotine, pH, and moisture. Analysis of various kind of flavors is another thing. We are part of the global project of e-liquid analysis for the for glycerol, propylene glycol, and nicotine, and we are in the making, and we are part of the preparation of global SOPs for analysis of flavors in these products. Other ongoing projects are as follows. The clinical services offered include screening and quantification of abuse substances, therapeutic drug monitoring for neuroleptic and benzodiazepines, and metal toxicity for lead we have started recently. These services are not limited to NIMHANS and adjoining hospital. Other government agencies like Indian Air Force, Director General of Civil Aviation, Indian Railways, and various forensic science laboratory also takes also send their sample for analysis. Teaching and training, with our experience, we do the teaching and training of doctors from Indian Air Force, forensic scientists of forensic science laboratory, and we also train scientists from the 5 tobacco testing laboratories across India. We regularly train postgraduate and interns from various nearby colleges. Started with the 20 samples in 2008-9. Now we have crossed 25,752 last year, and this year till date we have analyzed 15,061 samples. Future plan includes expansion of metal toxicity for other metal also, therapeutic drug monitoring for antidepressant and tricyclic antidepressant. Potency testing of existing drugs is the another need of the time, along with new psychoactive substances. Point of care detection devices for cannabinoid solvents and blood alcohol is another requirement, and the biomarkers for secondhand smoke and environmental pollution markers are also our priority. Thank you.
From the Department of Nursing. I'm here to tell briefly about the SAFE services offered by CAM. SAFE, an acronym which stands for Substance Abuse Free Existence. The SAFE service, it's relatively a new service which commenced only about 2 years ago on the 10th of October 2019, World Mental Health Day. The SAFE is an outreach community service from CAM offered at the NIMHANS Center for Wellbeing in BTM layout. These are the team members, that's myself, Dr. Padmavati, Dr. Prabhat Chand, and Dr. Pratima Murthy Madam. The main aims of the SAFE services: primary prevention of non-communicable diseases including mental health problems and health promotion by addressing the use of psychoactive substances as a major risk factor for these illnesses, and to help people adopt healthier lifestyles by addressing psychoactive substance use in integration with other factors that contribute to NCDs. The services which we have been offering both at NCWB as well as other community venues like these: psychoeducation, lifestyle modification, screening for substance use, harm reduction in order to catch people early in their drug use trajectory and prevent progression to more severe forms of dependence, facilitating cessation of substance use, referral to inpatient services at NIMHANS as required, support for individuals impacted by a substance user in the family, skill building workshops for the public, training health professionals and volunteers in helping individuals overcome substance use. The main features of the services that we offer: it's more of preventive and harm reduction, and when we address substance use along with other risk factors for NCDs, we find that people are more receptive this way. Personalized brief interventions. Vulnerable groups have been targeted. Our follow-ups are quite regular. We are receiving positive feedback from health professionals and volunteers who attended our workshops. We are presently focusing on strengthening the IEC interventions that we have, and with the lockdown conditions easing, we hope to expand further. Thank you.
The core PSW services include case management of both IP and OP care. Comprehensive psychosocial assessment and psychosocial interventions are the core activities. We work with individuals, family, and groups. The individual intervention includes orientation to illness and associated problems, behavioral management, skill building, personal and social skill, recovery and relapse management, chronic case management, and rehabilitation. When it comes to family, we educate and work with codependency issues, handling burnout, tapping resources, and helping in building internal and external family stability. Group work intervention are the core activities of PSW services. We conduct groups for drink refusal skill group, frequently relapsed clients, and family support groups. It is conducted in Kannada, Tamil, English, Hindi, Telugu, and Malayalam languages as and when needed. The clinical and non-clinical services include pre-admission counseling and pre-discharge counseling, welfare scheme initiatives and support for the needy patients, which includes disability certificates, BPL facilitation, and free drug facilities. Telephonic counseling during lockdown was another important activity that PSW team was involved in. Human resource development in the form of certificate course in basics of addiction management and other training services. Networking with government and NGOs are the other activities, which also includes home and agency visits. Some of the publications from our PSW team is almost 9 publications, and PhD and MPhil guideship were almost 9. Paper presentations, poster presentations in conferences, lectures, seminars, symposium, panel discussion, and training sessions were more than 100. We were involved in projects both as PI and co-PIs, which is almost 7. So some of the important projects are 5 days residential capacity building training program on addiction management for social workers working in Integrated Center for Addicts from Karnataka, funded by NIST, Ministry of Social Justice and Empowerment. Capacity building and training program for stakeholders under National Action Plan for Drug Demand Reduction, funded by Department of Social Defense, Government of Tamil Nadu. And prevention of drug use in schools, capacity building for peer educator volunteers, a pilot program, was funded by Social Justice Department, Government of Kerala. Some of the community-based awareness programs which are conducted by PSW team through media, training, and IEC material are as follows. The community outreach programs involve observation of special days that are World No Tobacco Day and International Day Against Drug Abuse and Illicit Trafficking. Some of the value-added services of PSWs are the development of IEC materials, videos, and street plays for creating awareness in the community. Felicitation of recovered patients, which are conducted at OPD, where we identify those who have not or stayed abstinent for almost 6 months and more are being felicitated. Group therapy for women with substance use disorder, orientation about addiction to various populations, psychosocial interventions to transgender community are the other activities, and the intervention at opioid substitute centers are the another activities. Some of the future initiatives that we are looking for are manpower development through advanced skill training in addiction management, evidence-based research to develop specific psychosocial intervention modules for vulnerable populations, information materials, videos in multiple languages, community-based intervention to deal with stigma and enhance treatment-seeking behaviors, collaboration with national and international organizations. These are our PSW team working at CAN. Thank you.
I'm going to be talking about 2 aspects which I've been involved in over the past 3 years. The first is with regards to capacity building in addiction medicine. And pertaining to this, I will be talking a little bit about the NIMHANS ECHO model. Now, the NIMHANS ECHO model, the basic principles, the ABCD, is amplification by the use of technology to leverage scarce resources, the sharing of best practices to reduce disparity, the utility of case-based learning to master complexity in management of chronic diseases, as well as a web-based database to monitor outcomes. Now, the NIMHANS ECHO model is something which has been used for training and capacity building in addiction medicine for the past 7 years. And it has been started and pioneered by Professor Prabhat Chand. And essentially, just for all of you to be able to understand things a little bit better, how the ECHO model differs from traditional telemedicine is, in traditional telemedicine, you have one doctor seeing one patient, whereas in the tele-ECHO model, what essentially happens is that there is an expert team, which is called the hub, which reaches out to multiple learners or spokes. So that is what is called the hub and spoke model. And these learners who are general practitioners or primary care providers or other health professionals would ultimately touch the lives of multiple patients. So as a consequence of that, there would be more patients or a force multiplication, which is seen with tele-echo programs. Now, we have been using this model of training for many years right now to train primary care practitioners. And so the initial training that which we had started off, was geared primarily towards primary care practitioners, both in terms of physicians as well as counselors, lay counselors from various parts of the country. So the goal was to be able to train across barriers of geographical distance as well as cost, and also to improve quality of training. And so in this context, a lot of the early work that was done by us was training of doctors and counselors from Bihar, Chhattisgarh, as well as from different parts of Karnataka in management of alcohol use disorders, drug use disorders, as well as tobacco use disorders. And this is something which is an ongoing enterprise. And of course, we have also evaluated outcomes and have generally found this model to be extremely effective as far as training primary care providers. And it was found to be feasible, it was found to be acceptable, as well as the outcomes in terms of overall cases seen, as well as the percentage of referrals, all reflected that this was probably a good model to use to be able to train primary care providers in the management of substance use disorders. Now, following this, after establishing the efficacy in the primary care provider group, something that we had thought about over the past couple of years was to also generalize this to be able to provide more advanced training for a group of specialists, essentially people who have already got competence either in psychiatry or specialists from other medical branches, but who deal with a lot of patients with substance use disorders. And so in that context, we have conducted 3 programs over the last 2 years, 2 for psychiatrists. One was which focused on advanced management of substance use disorders, as well as one program for hepatologists and gastroenterologists, titled the Program for Advanced Training of Hepatologists in Alcohol Use Disorder Management. Now, this was a program that we had conducted over 8 weeks, so 2-hour sessions every week for 8 weeks in April and May of 2021. We had participants for the first time, participants from different parts of the world, including the US, Chile, India, France, and Spain. These were all hepatologists and gastroenterologists with an interest in managing alcohol use disorders. And the program actually found that there were significant improvements in knowledge, practice, and self-perceived competence in management following the training. It was also an extremely rewarding and learning experience for all of us here to be able to interact with specialists and understand real problems on the ground. In addition to this, we've also been involved in drafting of several manuals for substance use disorders for the IMA Karnataka branch, as well as the standard treatment guidelines for the management of substance use disorders and behavioral addictions, which is hosted by the Ministry of Health and Family Welfare on their website. Now, the second aspect which I would like to talk about is probably a little different from training and capacity building, and that has got to do with our work pertaining to genetics of substance use disorders. And this is an emerging area. Of course, there's a lot of work which is being done globally, and there is a long tradition of work related to substance use disorder genetics, which has been done at the Center for Addiction Medicine in collaboration with the Molecular Genetics Lab at the Department of Psychiatry in NIMHANS. And we have continued some of this work in the past 2 or 3 years, focusing mainly on candidate gene studies, looking at possible genetic etiologies of alcohol use disorder. In addition to this, we've also widened our focus to look at genetics of alcoholic liver disease, specifically alcoholic cirrhosis. And we've looked at the role of both genetic variants in alcohol metabolizing enzymes such as ALDH2, ADH2, and ADH3, all of which were found to have some effects on the liability to alcoholic cirrhosis. In addition to that, we have also looked at epigenetic changes in alcohol metabolizing enzymes, and we found significant epigenetic changes in terms of lower DNA methylation in specific enzymes, which were linked to alcoholic liver disease. In addition to this, we've also been in the process of setting up many collaborations to conduct large-scale genetic studies, and these include international collaborations with researchers from the Psychiatric Genetics Consortium, SUD, or the Substance Use Disorder Working Group, and there are a number of ongoing grant applications which are in process. In addition to this, we've also set up a consortium called the IC Magic for multicentric studies, genetic studies in India, including studies of substance use disorders. Looking forward to the future, I think a couple of things which we would want to do going forward. One is to be able to establish a biobank which is linked to both electronic health records as well as physical health data. This is a strategy which has been used in genetic studies in different parts of the world, and it's something which we would want to replicate here, and it is something which we are working towards. In addition to that, training of researchers in different parts of India to be able to upskill and conduct large-scale genetic studies in India is also something which we would like to aim for in the next few years to come, as far as research in substance use disorder genetics is concerned. So this is the India Consortium on Mental Illnesses and Genetics in the Clinic.
ಹಲವಾರು ಸತಿ ರಿಲ್ಯಾಪ್ಸ್ ಆದೆ, ಮನೆ ಕಳ್ಕೊಂಡೆ, ಪೇರೆಂಟ್ಸ್ನ ಕಳ್ಕೊಂಡೆ, ಆಚೆ ಬೀದಿಗೆ ಬಂದೆ. ಆದರೂ ಈ ನಿಮಾನ್ಸ್ ಈ ಡಿ ಅಡಿಕ್ಷನಲ್ಲಿ ಇರ್ತಕ್ಕಂಥವ್ರು ಯಾರೂ ಕೈ ಬಿಟ್ಟಿಲ್ಲ. ಕರೆದ್ರು, ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದ್ರು, ತುಂಬ
Nigeria. I was a part of the just concluded 2020 edition ECHO, and I'm glad to have been part of it, and I'm grateful to the organizers and the facilitators. Two things I like so much about the ECHO sessions are the quality of academic and clinical discussions and recommendations that follow each case presentation. And number two, the very well researched, highly informative, and very practical didactics.
I take this opportunity to reflect upon my training at NIMHANS. So I did my MD in psychiatry, postdoctoral fellowship in addiction medicine, and DM in addiction psychiatry at Center for Addiction Medicine, NIMHANS. So during this training, during my 4.5 years of training in as a senior resident, I've been trained not only as a clinician but also as a researcher, as an academician, and also as a good administrator. So the training that I got from Professor Pratima Murthy, Dr. Prabhat Chand has immensely helped me in the position that I am currently in. So I have been able to collaborate with big agencies like WHO. I am also the initial person to actually start the OPD services here, and I have also been given some great administrative roles like OPD in charge at this place. So the training that I received at NIMHANS is an advanced level of training.